In terms of side effects, the study is very reassuring in that no major new side effects were identified. For the ruxolitinib treated patients, we saw a little more headache, a little more diarrhea, and for the BAT treated patients there was a little bit more abdominal pain, which is probably what you would expect if you're not able to reduce the size of the spleen. So those were the non-hematological side effects. We expect to see a degree of anemia and thrombocytopenia with any agent that inhibits JAK. And indeed this was seen in the study. All patients who entered the study had grade 1 or grade 2 anemia at trial entry, and more patients treated with ruxolitinib developed grade 3 anemia, but the rates of grade 4 anemia at the worst time point in the study were equivalent between ruxolitinib and BAT treatment. Just going on and considering anemia in a little more detail, when you think about rates of transfusion, again, the data here is quite complex. So more patients treated with ruxolitinib, 51% compared to 38% of the BAT-treated patients required a transfusion. When you drill down and look in more detail at the mean number of units each patient needed per month, the two arms of the study were equivalent. So that's suggesting that even if there is slightly more occurrence of transfusion, the amount of blood that these patients are getting when they're treated with ruxolitinib compared to standard therapy across Europe really isn't significantly more. When we consider thrombocytopenia, there was an increase in grade 3 thrombocytopenia compared to BAT treatment for ruxolitinib, but there was no increase in grade 4. And I think what this is telling us is, although this drug is causing some thrombocytopenia, it is well managed. And indeed, when one looks at the data for the study in terms of the number of patients who discontinue for either anemia or thrombocytopenia, across both arms of the study and in the extension phase, by which I mean patients who may have continue on ruxolitinib or have crossed from BAT treatment to ruxolitinib, there were only 2 discontinuations, one in each arm for low platelets and one across the entire study for ruxolitinib treatment for anemia. So that's really telling us it's there, but it's not really significant, and we know how to manage it. One of the most remarkable things about this drug, apart from the clinical and symptom control results that it delivers for patients, is how remarkably well tolerated it is. We can anticipate that the drug will cause a degree of anemia and a degree of thrombocytopenia, but the dosing regime that we were using in the COMFORT-II trial is allowing us demonstrably to control that safely and well. And other side effects are really not above what one would perhaps expect to see in a study where investigators and patients know what drug they're taking. So if you're a patient who's taking an experimental agent, you're much more likely to report symptoms. And if you're an investigator where you know a patient's using an investigational agent, you're much more likely to report symptoms than if you know that you're on control therapy, particularly where that therapy may be something you've been taking for a number of years. I think you have to assess the side effect data from COMFORT-I and COMFORT-II in a slightly different way. COMFORT-I was double-blind, placebo-controlled, so neither the investigator nor the patient, certainly from the point of view of side effects, could know whether they were taking active agent or placebo, whereas COMFORT-II is very different. The patients knew what they were taking and the investigators knew what they were taking. The other important differences are that none of the investigators for COMFORT-II had been part of the phase 1-2 trials with ruxolitinib, so we're not familiar with using the agent and were therefore appropriately cautious in reporting adverse events. Occasionally in the study we had to stop the drug, and either that might be because of a side effect, because the patient was undergoing another therapy, or sometimes for thrombocytopenia. And it's important to be aware that contrary to what one might expect, these patients actually tolerate stopping the drug very well. In my experience, no patients suffered an adverse event when stopping the drug. No patients had a dramatic overshoot in their cytokine levels, and nor were they very symptomatic.